Dr. Sudipto Pakrasi is a postgraduate from Dr. Rajendra Prasad Centre for Ophthalmic Sciences and the All India Institute of Medical Science, and started his career in 1984 as an ophthalmologist. Dr. Pakrasi has always set high standards in his professional life. A gold medalist during his post-graduation at the All India Institute, he was part of a team that was one of the first to start implanting IOLs in India in 1985. Which wasn't that long ago when you consider when we were doing it in Australia. And he has had the opportunity to be intricately involved in succeeding advancements and perfections in cataract surgery. Dr. Pakrasi was one of the first surgeons to do phaco surgery in Delhi in 1995. He's now a very popular speaker across the country and has been instrumental in teaching and popularising phacoemulsification amongst his fellow surgeons. Today, Dr. Pakrasi is recognised as one of the top cataract surgeons in India and heads a successful ophthalmic practice in Ashlock Hospital, along with his ophthalmologist wife, Dr. Kareen Pakrasi, who I see is down the back of the room there. Welcome. Eye Microsurgery Associates has taken special care to keep abreast with the latest technologies and best practices in the field of cataract surgery. Their guiding principle of quality surgery for the best possible patient outcomes remains a cornerstone of their very exclusive practice. Ladies and gentlemen, please welcome Dr. Sudipto Pakrasi.
Thank you, Nick. I just want to sort of say that I've been in Australia for the last about 13 days. It's been an exciting adventure. It's been my first trip. I'm here with my wife and my kids. I'm here to talk to you about a few of the things which it's been my journey. It's not to preach or teach anything to you guys, but I just wanted to start with this. The choices, if you really look at it, just for a historical perspective, in the 70s and 80s we had, choices of AC IOL, iris fixated. In the late 80s it was, in the bag or in the sulcus, choices, optic size choices. Early 90s we had the PMMA vis-a-vis the silicone, UV, non-UV. Late 90s silicone, hydrogel, acrylic, and single piece or multi-piece. So these were the essential choices we had earlier. So our life, I think, was very simple as cataract surgeons. But then, when you really look back and start wondering, is it all, is it the ultimate? Have I achieved it? Have I got the best solution in my hands today? You say, no, there are a lot of imperfections. For those of us who are beyond the age of 40, which I think very few of us are in this room, you probably are aware of presbyopic problems, like the inability to read. And that's where, we sort of start wondering that, why the hell do I need that? So what do I need? If I want to be a surgeon, I just look at the results. But if I am a patient, I would look at these problems. Quality of vision, better range of vision, possible spectacle freedom. Now that is where we all talk about what are the choices available to us today. Now, if you look at all these options, things are changing in a very dramatic manner. I think the UV, non-UV has been answered very effectively. Rigid versus foldable, even though we use a lot of rigid lenses back in our country, they're extremely cheap lenses. They cost about $1.20, and they're used extensively in eye camps now. These intracapsular surgeries, were not being done in the camps today. We are now doing phacos in most of the camps. That's where these non-foldable lenses are being used. Now, most of us have switched to the hydrophobic acrylic material. Monofocal single piece has been established. Toric has been, I think, extensively discussed in the evening. I'll probably just touch about that in one slide. And extensively, I will be wanting to discuss about the multifocal, the restores in particular. In future, we have more options coming up to us. The multifocal Aspheric Toric, the phakic, the customized IOL. And I know, and all of you know, that ultimate IOL can never ever be made. Now, a very brief discussion about my sort of intention is not to talk about the theoretical aspects of it much, but to tell you that we all would like to see, like the picture on the left, not the one on the right. So there's a new dimension which has come into cataract surgery now today. It's not the Snell's chart anymore. It's not 6x6 or 20/20. It's the quality of vision. We are not measuring contrasts as a routine. Some people have gone into it, but it's not a standard procedure all over the world. Now, if we just look into the theory of it, now, the cornea, extensive evaluations have shown, has got a plus 0.27 microns of spherical aberration. Now, what that means is that the peripheral rays, if the pupils are dilated beyond approximately 4 millimeters, the peripheral rays get into focus in front of the retina. So you get two focal points. Now, the young lens of the eye has got a negative spherical aberration. So what it's doing is exactly the opposite. So if you have a system which combines the two together, you have a zero spherical aberration. That's a 20-year-old's eye. So he is actually getting this corrected by that, getting a perfect focus. However, like most of us in this room, our lenses have become like this. They are showing some positive spherical aberration. So it is mimicking what is there on the cornea, and if you add the two together, you have a significant amount of spherical aberration. Now what this does is, we're still seeing very well, but over a point source of light, there would be some halos, and things will not be as clear as one wants it. So when one had these standard monofocal implants, what it was doing was it was actually being able to induce some positive spherical aberration, giving us a vision like a 55 or 60-year-old. Now that's what standardly has been available. Now with the aspheric lenses, theoretically, we can actually now achieve this, mimicking this kind of a lens, where this will counteract, giving us a near young vision as possible theoretically. Practically, you know and I know it's not possible. So it is a jump from what we had to a better quality of vision. That's what we are looking at. So this is a concept which works essentially more in the evenings. My friend Warren Hill has supplied me with this picture, a simulation of what happens between a normal standard implant vis-a-vis an aspheric correction. Now that is what we would all like to see with. Now, sort of having that, there's one more aspect about, some people talk about the range of vision, the focusing problems, issues about, what is the amount of distance which you'll be able to see very well. If you look at this focus, it comes into a single point focus now. But if you look at the periphery, this edge, if you look at the sort of thickness here, it is probably better than the thickness which you have in a standard monofocal implant. So even if you're using this, now yes, the best corrected vision has got a very small range, but if you look at the range here, it's better than what you have here. So you actually don't lose anything. You're not losing much once you're using this kind of a technology. Now these are the profiles of the three kinds of lenses. My intention is in no way trying to compare the three, but to tell you that there are three different kinds of aspheric lenses available in the market today. The biggest advantage which we have, that the asphericity, are three different types, which I will make you understand what the advantage is in the slide after this. But this has got a thinner edge. Now there's a 9% reduction in the central thickness of the IQ lens. It makes it a wonderful implant for us to actually sort of implant through the sub 2 millimeter and the 2.2 millimeter incisions. Now if you really look at a 6 millimeter pupil size and compare the three available lenses, now what is happening is that the Acrosoft IQ has got a 0.2, a minus 0.2. Thickness minus 0.27, and a soft port AO is a 0. This means this is a negative spherical aberration being induced by these lenses. So what we have in result left is a plus 0.1 here, 0 there, and a plus 0.28 there. So we have three separate scenarios with these three different kind of lenses, which now we come to the summary of this lens, that it adds a 0.2 negative spherical aberration, leading a plus 0.1 overall positive spherical aberration. It's a thinner aspheric optic, and it can go through very small incisions. Now this, if you are looking at placing most people at a plus 0.1, and we look at two standard deviations from here, and we look at the IQ lens, and this is what is going to give us two standard deviation. So we should be able to cover most of the people as we think, in this range. However, if we have the thickness with a minus 0.27 induced, if you look at the standard deviation, that's what the curve becomes, and with the soft port AO, this is what the curve is. Now, ideally speaking, all of us should be measuring the spherical aberration of the cornea. Now, this is something which we never knew about 2 years back, or even a year back. So we should ideally be measuring the spherical aberration and then choosing which particular lens should go inside the eye, because there would be some people with high positive or a high negative spherical aberration, which you may be in error if you use this, or even this. So if I may need to ask, how many of you actually routinely measure the spherical aberrations of the cornea before deciding about your implant? Anybody in this room is measuring? So if I want to play safe, if I'm not trying to measure the spherical aberration, where am I the safest? I'm safest probably if I'm using this range. Because if I'm using a 0 range, if he's got a minus error, I will be making him much more minus than what I normally should. So that's why, I have I need to sort of also realize that we will need to change the way we do our pre-op workups, and we need to do the spherical aberration correction. And the measurement will will indicate which of these lenses. So that will be the ideal situation. A word of caution about people undergoing hyperopic LASIK, because they do develop negative spherical aberrations, and if you are adding a more negative spherical aberration, one would not like it. And during surgery, of course, if you have any of these situations where the centration of the lens is a bit of an issue, then I think this should be abandoned. One should not put in the aspheric implants in these situations. Just a brief mention about the Toric implant. I think you all know about this Toric. Unfortunately, Toric is not available to us in India as yet. It is going to be made available by end of next month. I hear that a lot of you people have been using the Torics very successfully in your practices, and it's been giving you wonderful results. So this is a definite choice which will obviously increase our armamentarium in our choices. You all know about the restores. And I believe a lot of you have been using the restores in various percentages in your practices already. I'm not going to talk about the restores, what it is made of, but it essentially gives, according to the FDA, 80% spectacle freedom. It provides very good near and good distance vision, and intermediate is moderately good. And the incidence of optical disturbances, even though they're there, are low. Question is 6x6 enough? You know it's not enough anymore. The people who elect to pay for a premium IOL, they want premium surgery and a premium result. Now, unfortunately, in our country, payment is a big issue because people are not covered for insurances in most of the situations. In Australia, I believe it's not an issue, but it is a thing where even if any patient for you of yours knows today that the insurance is paying more, he would want something better than what he is expected. We have always had this thing that we cataract surgeons and them refractive surgery patients, or the surgeons who are doing just LASIKs and PRK stuff and all that. There's been a huge divide even in our country. It is a time to converge the two lines together to make sure that we understand that it has to be worked together. We need to change our mindset, otherwise we will never really improve. Question is, why did I change and how did I change? Because we know that there is an emergence of refractive cataract surgery as a super specialty in cataract. I mean, 6x6 again is not enough. Patients' expectations and demands, etc., are increasing with time. And I was certified in the end of 2004. It took me nearly 9 months to get myself to practice my first restore. Because I needed to understand this lens extremely well. I needed to know where to put it. And unfortunately, the kind of practice we have in Delhi is a very exclusive and a very high society, and people who really are well aware of things, and the expectations and demands are very, very high. The first patient we did was the wife of the director of the largest corporate in India. So it was something which I had a problem. Question is, when a patient comes to you, how do you choose? Now, the way I go about it is different in India, and if I was in Australia, I would have gone about it in a different manner. Why? It's a question of money, the question of payment, insurances. Now, most people, when we ask them, are you insured? You're not insured. I know it's a bad way to go about it, but that's the way it works back in our country. So if there's no demand of any vision, we say, okay, you have insurance, we will do this for you, and that's what it is, that's it. Somebody who says that I want better quality image, we will offer them the IQ. Somebody who will want correction for astigmatism, we will offer the Toric when it comes to us next month. And people have been wanting spectacle freedom, we will offer the restore. And this is obviously in the future, this is in the annual, I'll discuss about that later. Patient benefits with the multifocal IOLs are tremendous. You have lots of advantages of a multifocal. Anybody who's been a presbyopic and does not wear glasses would realize what the advantages of having multifocality is. The dependency on the glasses or lenses becomes minimum, and there is increased range of focus, and there's definitely a quality of life improvement. I've had people, we are exclusive cataract surgeons, I have not had people coming back and saying you've changed my quality of life, and that's what has happened with these lenses. Our concerns as surgeons to start, what took me 9 months, were these issues. Expectations of patients are very high, and there's much more chair time for, which is required for counseling. Biometry assumes extremely, extremely important extreme importance is achieved with this, and high skills of surgery is involved. And you were concerned a bit about the unwanted visual images and the loss of best corrected vision, and that's what holds you back. So once you have gone through all this, then you start looking at your practice and start wondering, how do I